Okay, we move on to Professor Angele here from Munich. It's I think needs to be mentioned that surgeons are interested in liquid biopsy. I think that's I would say the German word is lobenswert. I don't know it in English right now, but he's understanding that. So we are trying or having a cooperation already with the surgeons from the University Hospital, and I'm very happy that Professor Angel is here. And there are some clinical needs really for some patient groups to improve treatment and guidance of therapy with liquid biopsy. His talk is possibility of ctDNA to guide treatment in colorectal cancer, but I think there are also other groups that's also really urgent, like pancreatic cancer and so on and so forth. So for today, we will hear about colorectal cancer. And once again, thank you for joining in and giving a talk here on our symposium.
Thank you very much, Professor Holinsky-Feder, for the invitation. I'm really honored to be part of this meeting today because I feel a little bit like a clinician, and with so many specialists, it's really amazing. But nonetheless, I think that integrating clinicians into those concepts will really help to bring it into clinics, and therefore the clinician is also involved. And I will try to give a little bit more the insight from the point of a surgical oncologist, how ctDNA could be used in colorectal cancer. There will be some overlap with the talks before, but this only indicates that the most important studies and the milestone papers will be also cited in my talk. When you look at ctDNA in the clinical course, obviously the surgeon is involved starting at this area where the diagnosis has been made in the clinical scenario, and then the surgeon performs the surgery or is integrated into a multimodal treatment concept for the patient with a neoadjuvant and adjuvant therapy. And certainly the surgeon is involved when looking at a clinical recurrence, and maybe in combination with a systemic therapy, a local therapy, again, can be applied. From the point of view at the moment, if patients are integrated into ctDNA concepts or in molecular tumor boards, most of the patients are treated in this phase of their clinical course. And I would really try to emphasize that it is important to start with molecular markers and with liquid biopsies at this point of clinical diagnosis or even earlier. So what I would like to introduce today within my talk are those four aspects. First is the ctDNA to be as a prognostic marker and as a marker for risk stratification, also for inclusion of patients in clinical studies, because when we only include them based on the TNM classification, we really have a very heterogeneous tumor biology and a very heterogeneous group of patients with respect to their prognosis, irrespective of similar tumor status like the TNM status. I would like to say something about the response to therapy. The complete response has already been indicated. For the follow-up, and I would call it the molecular resection status, and the therapy guidance, in particular the adjuvant therapy guidance. And the aim of it is to improve the patient selections for clinical studies, to guide the therapy with a personalized treatment, and to avoid under or over treatment. This study already has been cited, but not from this point of view. It's here stage 2 and 4 resectable colorectal cancer, which have been treated in the circulate trail. And this is the observational arm, and they call it now the Galaxy study, and this will be cited again a little later. But what you can see is that the circulating tumor DNA after resection discriminates very well between two groups. And what is really interesting is this multivariate analysis. We would normally discriminate the patients based on their T status and on their lymph node status. But looking now at the hazard ratio, which is generated in this study with over 1,000 patients, you can see that the T status is not so well discriminating between the groups. Much more discrimination can be achieved by the detection of the circulating tumor DNA with a completely different hazard ratio, indicating that for studies and clinical studies, homogenization of the patient collective would be much more easily achieved, or would be much better using the circulating tumor DNA. And I would call it the molecular resection status, which makes us surgeons like almost molecular surgeons if we integrate this in our concept, and makes it a little bit more novel. Is this correlation only after the primary tumor? No, it's also detectable in patients in the metastatic state if you only take the stage 4 patients. And this is a meta-analysis integrating studies in stage 4 patients at the baseline. In this and postoperatively after resection of the tumor and post-chemotherapy. And the most interesting group is this one here, the post-resection group. At the moment, no patient after liver resection receives, if it's an R0 resection from a histopathological standpoint, receives the chemotherapy. But as I had shown you, or as you can see here, the evidence of ctDNA positive liquid biopsies after resection may be a very good marker to discriminate patients who would profit from adjuvant therapy or no adjuvant therapy after liver metastasis resection. The aspect of peritoneal tumor DNA has been already indicated. In this study, I would like to show you, it's a very small study, very small numbers. It's really, it's small, but what you can see, even the detection of peritoneal tumor DNA with negative and positive can discriminate between those two groups. What is interesting about this aspect? First, peritoneal tumor DNA probably will not act in exactly the same way as the circulating tumor DNA in response to chemotherapy. This we would like now, at the moment we have launched a study in the gastric cancer, and we would like to detect this discrimination between the peritoneal tumor and the circulating tumor DNA. What is also interesting from a point of view from a surgeon, with patient with positive peritoneal tumor DNA and negative circulating tumor DNA, maybe integrating HIPEC intra-abdominal chemotherapy would add, by intensifying the local therapy to the patient, would help him to get a better prognosis. And so therefore the peritoneal tumor DNA from a surgical point of view is very interesting, but there we are at the beginning and we do not have a lot of data on this. The response to therapy is very important for a surgeon. And this is important in particular for the rectal cancer, where concepts due to the life quality, where complete response can be achieved by intensified chemotherapy and radiotherapy, the patient is included in watch and wait concepts, where you only control the primary tumor and you hope that he has a complete response. When you look at the ctDNA levels in a patient with rectal cancer who is getting radiochemotherapy, and I think this is a really interesting paper, at the baseline, the ctDNA is not discriminating so much. But when you look during the radiochemotherapy, the discrimination is increasing more and more. So if a patient is negative after the radiochemotherapy preoperatively, the circulating tumor DNA is discriminating very well between the long and the short survivors. So at this point of view, maybe you could stop and just perform a watch and wait concept. And this study is addressing this, a very new one from 2021. And in this patient, when you use the ctDNA alone, you can discriminate already quite well between a partial with a pathologic complete response and no pathologic complete response. And if you add the MRI information, to the ctDNA information, you get really a good a prediction value to predict who patient has a complete pathological response and who has not a complete pathological response, which has a very high implication for the patient, avoiding surgery in patients with a low rectal cancer. Another aspect is if you try to determine the response to chemotherapy or to, for example, here to EGF receptor therapy, you can detect in the plasma different mutations. And in this case, you can see if you give an anti-EGF receptor therapy, you have an increase in the ctDNA with EGF receptor mutant with mutant clones. And once you stop the therapy or withdraw the standard chemotherapy, you see that those ctDNA is decreasing. And once you can, when you see an increase again in the tumor load, you can re-challenge the patient with EGF receptor therapy, and thereby you can really modify your systemic therapy based on the clones you can detect in circulation, which certainly will improve the efficiency of the chemotherapy on the one hand, or the systemic therapy on the one hand, thereby avoiding unnecessary side effects. And again, I would like to now come with a follow-up after the surgery and the molecular R status. And what I had shown you before, and this information I think is again very interesting, in all stages, the presence of circulating tumor DNA can predict recurrence after resection. And this includes the lower stages here, 1 to 3, but also the stage 4 patients. The detection of relapse is much better using ctDNA, and therefore it's really important to integrate the ctDNA early at the first diagnosis to know whether the targets which you target with the ctDNA panel which we are using, whether you will be able to detect the recurrence early. And the recurrence will be detected much early as opposed to CT scans, which on the one hand is probably cheaper than CT scans at many times. It's more accurate, and it also helps the patient to feel much more safe in his course after resection and for the detection of relapse. The therapy guidance is very important and has been now has been highlighted many times today. But certainly I maybe have a little bit more different aspects adding to it. And this will probably for surgeons in the next future have the most clinical implication, since we really always guide our adjuvant therapy at the moment only based on the T and M classification. If you have a ctDNA positive patient, you can, by using chemotherapy, in some cases, achieve a ctDNA negative patient status. So you really can, to some extent, bring a molecular R1 or R2 resection into a molecular R0 resection. And this is the case in those studies which are here taken together. And you see here the percentages. It's between 20 and 70% that you can convert the molecular R2 or R1 status, however you call it, into an R0 status. And this would be really important when you discuss adjuvant studies, because this would then homogenize your patients for those studies. And this should be the studies designed in the future for solid tumors, gastrointestinal solid tumors, when you discuss or when you generate adjuvant systemic therapy studies that you discriminate between ctDNA positive patients and ctDNA negative patients, and then randomize those patients here with the ctDNA positive status into the novel adjuvant or in the standard therapy. This study has now cited many times. I think I would like to highlight one aspect which I find important. The characteristics between those two groups, which were randomized into standard management and ctDNA guided management, was similar with respect to the TNM classification, with respect to the risk, so tumor biological risk based on the left versus right colon, to the MSI status, and also to clinical risk groups. What you can see is that in the ctDNA guided groups, the number of patients receiving chemotherapy was 15% versus 28%. This is a reduction in chemotherapy by 50% based on a ctDNA guided therapy where only patients were treated with adjuvant chemotherapy if the circulating tumor DNA was positive. But I think which is also important and really is maybe another very important aspect, the patients which were ctDNA guided, had a ctDNA guided management, received a much more intense chemotherapy. In 62%, they received the oxaliplatin-based doublet, as opposed to 10% in the standard treated group, indicating that a risk-stratified adjuvant therapy justifies a much more intense chemotherapy and also allows that the patient allows to convince the patient from such an intense chemotherapy concept. This and this resulted that the reduction in chemotherapy, the adjuvant chemotherapy by risk stratification, resulted in a similar survival, and the intensivation of the chemotherapy in the ctDNA positive group really improved the survival of those patients. So what is important is that on the one hand, you were able to decrease chemotherapy in this group, and by intensifying the chemotherapy in this group, you improved the survival. This study I had cited before, the Galaxy trial, and now I would like to show you a different aspect to it. If the patient was ctDNA positive 4 weeks post-operatively, the adjuvant chemotherapy was effective. It really changed something in the patient. If the ctDNA was negative 4 weeks after chemotherapy, the adjuvant chemotherapy after surgery, the adjuvant chemotherapy had no effect. So only side effects were present in this patient group. And if you can convert the patient from the positive group to a negative group 3 months after, you can achieve, by intensifying the chemotherapy, a very good result for the patient. Is it now important in those watch and wait patients which have no ctDNA 4 weeks after surgery? Yes, it is important, because this group which developed ctDNA 3 months after had a really bad survival comparable to those ones who were positive at the beginning after the resection. So it comes to this point that the adjuvant chemotherapy should be tailored, like in the negative group, the opportunity for de-escalation of the standard treatment is possible, but in the positive group, an escalation of the standard therapy should be performed. So I would like to summarize that the ctDNA in colorectal cancer may allow a prognostic, have a prognostic value, and may allow a risk stratification for the patient based on their tumor biology, but also may allow to give like a molecular R status in addition to the histopathological status, and thereby may allow to tailor the adjuvant chemotherapy, avoiding unnecessary morbidity, intensifying therapy if reasonable, and avoid resistance by regularly controlling potentially resistant clones. And this will lead to a more patient-orientated from a disease-orientated treatment, where surgery plays also a role in this multimodal treatment, but the response to therapy and the tumor biology may be clarified by the ctDNA in the plasma. And therefore, now I thank you for your attention.
Lieber Herr Professor Angele, vielen Dank. Oh, sorry. Many thanks for this very clinically oriented talk, which is important for the audience because there are many clinicians here online. There are no questions in the chat. I would like to encourage people to ask some questions. For me, it would be interesting. Right now, we only have one CT analysis for guiding therapy. For the ones who turn out negative, for how long would you think we have to go on with repetitive testing to make sure that the ones who are negative stay negative?
The only information for this is, at least I think at the moment, is with a higher or bigger patient collective, is the studies that I showed you at the end, the Galaxy trial. And in this study, they showed that it is reasonable after surgery, after 3 months, to redo the ctDNA analysis in order to detect those patients which were negative and then turn positive. Because in those patients, intensifying the adjuvant therapy would be reasonable. From a point of view, when you look at normal tumor markers, you would control them every 3 months and then after 6 months, after 1 year. I think at the moment we could only rely on this information. But what I think would be really important to integrate this novel diagnostic tool, I think it would be important to connect those academic institutions at the moment to get results from clinical studies more rapidly, in order to convince the insurance companies that it's important to cover those costs in the clinical arena. Because at the moment, it's really hard because it's not covered. The institute covers a Da Vinci system, but it does not cover the detection of biomarkers, which may be more important from a oncological point of view.
Yeah, but as we know, we've never opened up their pockets straight from the beginning. It's always been tedious with everything new, but we have to insist and we will make it. I think there's no way out for them. Liquid biopsy has a really important position in therapy guiding, and that will be accepted one day.
I agree.
Yeah, and it's for the future for these patients. Like we know now from the breast cancer people that they can have really late relapse after so many years. So liquid biopsy will become an important tool in doing surveillance in these people. I think that's a huge step forward in therapy guiding, really risk adapted therapy guiding. One last question. One of these patients turning from negative to positive on liquid biopsy, was that also visible from the clinics, like from radiographs, from endoscopy, or only liquid biopsy with a really high sensitivity?
I don't know from this study, but in particular in the upper GI tract, there are many studies that tried to compare PET-CT scans, which may detect lymph node metastasis, with ctDNA analysis perioperatively. And the information from the PET-CT scan was much lower than the information from the circulating tumor DNA. With respect to prognosis, and thereby justifying like a risk stratification. So I would assume that in those patients, the detection radiologically would be much behind after the ctDNA detection in those ones after 3 months after colorectal surgery.
That's another argument for liquid biopsy. You know, it's sensitive and it saves money on the other side.
Absolutely.
Yeah. So with this, I thank you very much. Hopefully we have a good collaboration in the future, being the part of the directors from the University Hospital here in Munich. Thank you for joining in, for giving us this clinically oriented talk, and well, probably we'll meet again in the near future.
Yeah, I
Thank
guess
you
so.
very much.